This video is the second in the series, so I suggest the most important part of the series is usually the first one. For these kinds of videos, the first one tackles the most pressing matter, and I suggest that if you haven't seen the first video yet, it's about the initial impact, the shock, the confusion, the fear, and I suggest you go there first. In some related cases about a family who suddenly experienced COVID, a sudden case of COVID in the family, and this is a very rapid, severe case of COVID. Within 1 to 1.5 weeks, the patient was dead. So that's the case. We'll try to consider other ways of looking at what's happening during this time. And the topic for the day would be, you die the way you live. You'll react to the death depending on how you prepare yourself for death. Or you'll die depending on how you live your life. You won't react based on somebody else's person. You'll react based on your own person. It's pretty obvious, but no, it has to be pointed out. Even something as obvious as this, I mean, how would you react? Well, you'd react based on who you are. The fancy way of saying it is, you die based on how you live. You react based on who you are as a person. It's pretty obvious that there's no one way of reacting to that. In medical school, nursing school, undergraduate school, we always get taught about this very classic idea of, we call it DABDA, and D-A-B-D-A. Denial, anger, bargaining, depression, acceptance. And the idea is, when we talk about how people react to that, we just think about those things and we're pretty much set. Of course, a simplification. The reason why we like that idea is because something so complex or complicated and very personal seems to be very simple. Now, you have to understand, if you were in Kubler-Ross's hospital in that community during that time period, dealing with the kind of patients she's dealing with. So she's dealing with a particular class of Americans in a hospital, tertiary hospital at that, in academic care setting, not dying right away because she had time to interview most of them several times. Then you go through these stages. I mean, how can she figure out the stages if she hasn't had the experience of interviewing someone who's going through the journey several times, right? So now there's a big difference right now with our case. Our case is, they don't think they're going to experience COVID. COVID strikes, the family member dies. Okay, that's kind of different. Okay? So the question is, how would you react to something so sudden, so severe that would result in death? Now, it's different compared to how you would react to something that's not sudden. It takes several months or several years, during which time you experience all sorts of hardships, suffering, good news, bad news, more protracted, it takes longer, and you experience all sorts of things. Sometimes you feel like you're about to get cured, so happy, you don't feel like you're sick, and then suddenly you get worse, and then you're in the hospital, and then you're back again, and it's up and down, and you gradually deteriorate. I mean, that's a different experience. Illness would have different trajectories. That's why the first few chapters in any end-of-life care book would be to remind you that death has different trajectories, right? You know, you're well, something happens, you're dead. You're well, something happens, but you don't die quickly, but you progressively deteriorate and there's no good thing that happens in between. Or you're well, you get stabilized, you get worse, you get stabilized, somewhat well, you get worse, and then suddenly you're dead. I mean, there's all sorts of trajectories. Just to remind you, it doesn't follow the path we want. The path we want is, you're about to die, but you still have time, and the hospice people and all your doctors have time to deal with you, and you have time to work things out. And then when you arrive in the hospital, before you get put on a ventilator, people already tell you what might happen, and then you get to prepare yourself, you get to anticipate it. Your family members get to prepare themselves, and then you get on a ventilator, and then things don't work out, and then they sedate you, but then you've had enough time to prepare yourself. So that's the key word, preparation. When did the minds of the other family members and your other relatives and your personal doctor entertain that idea? Because that would mark the beginning of them trying to prepare themselves for that eventuality. So you're looking at everyone trying to anticipate what might probably happen, praying that it won't, most hoping that it won't. And that's the difference. That's the difference between that and our case. So our case is really sudden. So the reason why the first video is more important is because most of the time, the way we do things right now is, it all ends up with a shock. That's the way things are set up right now. It's something that's sudden. People don't want to think about it. And right now, this pandemic has been going on for too long, and they're trying to be positive. They're saying that it's almost over, and they're trying to open things up, and people don't want to think about it. They want to think that it's all gone, right? So that's the general sentiment right now. And it will probably change if things get obviously clearly worse again. I don't think it got better, but that's just my opinion. That's how things are right now. So there's more of a shock. You're thinking this way, and then something happens to remind you, no, that's not the case. And when you enter the hospital, everything is in chaos. Right now, the healthcare system is trying to cope with a lot of cases. I mean, the emergency rooms are swamped. The hospital system is swamped. I mean, there's chaos inside. I mean, there's a sense of disorganization inside. I mean, I'm not saying that it's total chaos, but it's confusing inside. Now, if somebody's already in shock or confused about what's happening, and then they get exposed to this kind of hospital or emergency room, then it's even more confusing. And then you don't get to interact with each other. It's a COVID thing. You don't want to infect people, and you don't want to get infected by your family members. And suddenly, the dying person is stuck in a ward, and you can barely talk to them. You have to wear the protective suit, or you just have to talk to them using the tablet or the screen. And, not all places have enough resources to provide you with a tablet 24/7, right? And even if you have a tablet, the patient himself or herself won't be able to look at that tablet for too long. And they're experiencing a lot of symptoms and distress, and you're probably getting some medications to relieve those symptoms and distress and anxiety, and that's going to limit the way they'll be able to interact with you. And then they start asking the patient and the family member about certain things. By the first week, they were asking the family to think about eventual death. The care providers never told them that he's probably going to die right off the bat, especially in that kind of confusion. Some would, but most of the time they won't. They try to be positive. That's the way the system works. You try to be positive at the beginning. Actually, there are several studies showing that we are too optimistic, even near the end. You die based on who you are. You die the way you live, referring to who you actually are, not referring to the way you project yourself with friends because you want to appear like this and that. That's not what I mean. I mean, who you are when you're faced with crisis so severe that it's almost like dying. Of course, you get to experience death only once, but you might have a near-death experience, and then that would have clue us in, or you might have experienced a very terrible personal crisis, and that would clue you in. If you want to sit down and try to figure out how you reacted, and that would give you an idea or some kind of clue how you react if you're that person in the ward, in the COVID ward, who's about to die. The studies are nice, but the studies are extremely limited. Why? Because death is a very, very personal thing. Surveyed a gazillion people in the Western Hemisphere, and but added a little bit of people from the other continents, and then randomized it and came up with like statistics like 20% thinks this, and then 50% thinks this, or 80% thinks that. And it doesn't matter. I mean, who cares, right? So what really matters is how this person lived and what this person thinks, right? So the way this person would react would be based on his person, and not, he won't try to follow the 20%. And you don't even know whether he's the 5%, right? When something becomes more personal, when the personal becomes more important, then the surveys in the literature, the medical literature, that tries to make us feel that everything is scientific and predictable becomes clearly and obviously lacking, right? So and that's the situation. So now we'll go through some of it. Some people close up. They don't want people to tell everyone about it. Don't call our other family members. People will even say, don't call my kids. It's just between you, the spouse, and me. I don't want them knowing about this. We'll just deal with this on our own. Some people are like that. During times of really severe, the most common reason that I've encountered is they don't want to cause a lot of suffering and hardship and burden to others. So, I mean, if they're dealing with children, they don't want to cause emotional suffering and don't want to be a burden to their kids. Now, if there's something problematic about this, by not telling your kids or by not telling your closest friends, you're depriving them of preparation, depriving them of adjustment. They won't have time to prepare themselves and adjust. You die, somebody tells them, they're in shock. They never get to talk to you. They never get to prepare themselves. That's pretty much what happens to them. The burden was prevented at the start, or what you thought was a burden or difficulty was prevented while you're alive. But then when you died and somebody told them that you died and there's no way for them to see you or talk to you or prepare themselves. And if they're really that close to you, it will take time for them to adjust. And it's easier to adjust if you had a chance to say goodbye and if you had a chance to tell the dying person everything you want to tell them. Usually, if it is so fast, things are happening so fast, then what's probably the most helpful things you might want to say? If somebody gives you a tablet, and he's going to get sedated, and he probably won't wake up, and then he'll die. So this is your last chance to talk to each other. It's all sorted out, the CPR, and it's really bad to think that sometimes the final words exchanged between the family members, do you want CPR or not? That's the last thing they talk about it, which is terrible, right? Now, assuming that's not the case, so they already decided on that, and the patient already knows, and he's about to get sedated, and he'll die. So what's the best advice? Well, usually the thing that works, you choose among these things, or you try to cover these things. Thank you. We love you. It's a mutual message exchange. It's the same message as exchange between the dying person and the family members, the closest ones. I'm glad that I've spent my life with you. Thank you for being my dad. Thank you for being my daughter. And then the dying person tells the family member the same thing. And then, I love you. Family member tells the dying person, and the dying person tells the family member that. And you try to cover any areas of conflict. Fights were unresolved. Sources of anger and conflicts before that were not resolved. And you kind of bring it out in the open, and then you forgive each other. And that's pretty much it. Right? I'm sorry. I forgive you. If you cover those things, usually that takes care of it. Usually, again, dying is a very personal thing. You can just simplify it into 3, 4, or 5 statements. Of course, the final one is goodbye. It's okay for you to die, will be okay. That's goodbye, not goodbye to riddance, not that one. It's okay for you to die, will be okay, don't worry about us. So the I love you part, and thanks for being my dad, or thank you for being my mom. I'm also happy that I've lived my life with you. That brings up the idea that your life has meaning, or our life shared together has meaning. It's all worth something. The time spent together has meaning. It's worth something. Of course, before you get to say those things, you have to clear the air. So the I'm sorry, I forgive you part goes first, right? Clear that one. Take that out of the way, and then you go for thank you for, and I love you. And the goodbye, it's okay, we'll be fine. And that's pretty much it. That's one long discussion. But just in case I don't get to do that session for a long time, at least I told you. Some people react to a crisis, like really bad crisis, by looking for reasons why it happened, and they get angry. Whose fault is this? It could be anyone's fault. Anyone who did something, and that's the reason why they ended up about to die, or anyone they perceive is the culprit. That's the object of their anger. It could be one entity, it could be a couple of entities. It could be the doctor, or the nurses, or the system, or the government, or the hospital. It could be one family member. It could be the one who's taking care of mom, and she didn't do this, and she didn't call the doctor up. It could be the family doctor they called up 2 weeks ago, who advised them only to do this, and it turned out it wasn't a mild cough and cold, and it could be anyone. The problem with experiencing death in a state of anger would be the person dies and then the anger remains. Now, the person is about to die, or somebody sedates you, and your last emotion while you are conscious is anger. If I ask everyone, you want to die feeling angry, and the majority will say no. Everyone aims for acceptance. That's the reason why Kubler-Ross placed acceptance as the final goal. Acceptance would lead to dying in peace, dying without severe emotional, existential, spiritual suffering and anxiety. Acceptance. That's the reason why it's there, final goal. But just because it's the final part of the DABDA list, it doesn't mean everybody gets there. Especially if things are so fast that things happen in 1 to 1.5 weeks, like our case right now. This happened really fast, so you can die with anger, you can die in shock. The way things are right now, things are really crisis mode. There's like second waves and third waves, and hospitals are getting overwhelmed all over the place, and it will probably get worse later on in Europe and Western Hemisphere, even in Asia. A lot of people are dying in fear, confusion, and anxiety and shock, which is not good. My best advice is, when things start happening, don't forget the psychosocial, spiritual, and the supportive part. Don't just try your medical science and hope for the best, and that's the only thing you'll probably do, because as of now, we really don't have much to offer. The person enters the emergency room experiencing what looks like severe respiratory distress, especially if this person looks like he's going to end up on a ventilator. There's a huge increased likelihood of death, right? And you don't tell them that that's going to happen one day before you sedate the person, one day before you send the patient into a coma or knock out the patient's consciousness, and then the patient dies, and that's pretty much it. No final words, no nothing, no interaction. So the patient has to deal with that. He's alone in the ward, Now, some people prefer not to talk about it, not to think about it until the very end. And I would guess the kind of person who don't want to think about it until the very end is the kind of person who is afraid of death. If you're so scared of something, or so fearful, and your brain freezes out, then your brain does everything, or your mind. If you're so scared of something, you're so anxious, you're so fearful that it freezes up your mind. And of course, nobody wants their mind frozen up. And the mind itself doesn't want to be frozen up. So the defense mechanism is not to think about it. So what's the solution for that? Well, if it really can't handle it and it gets that bad, and it's probably doing the right thing. If there's a way to decrease this fear of death and this severe anxiety, then the mind might not need to resort to that. I don't want to think about it. It's gone. Don't remind me. It's gone. Of course, that does a couple of not so good things, right? Well, how can the spouse who wants to say her final words talk to this person who doesn't want to think about it? Well, maybe. I think you can still say, I appreciate my life spent with you and I love you, without considering the idea that this person in front of you is about to die in the next 1 to 2 days. It can still be said. The son or the daughter can still say that without bringing up the idea that their parents are about to die in less than a week. Too much. Right? Talk about thankfulness, love, and appreciation without bringing up the death part. I think it's possible. Even the sorry and I forgive you can be done without that. So I guess it's possible once. It will complicate things. They cannot ask the patient directly. For the patient to answer that, well, first he has to listen to the information, enough of the details, and then he has to really think about it so that he can give them a good answer, like whether he wants to be fed, whether he wants CPR. That's a lot of thinking about what you don't want to think about. And the problem is, even if you listen to the information, your mind freezes up. That's the reason why you don't want to think about it. The only solution would be to prevent the mind from freezing up. So decrease the fear and the anxiety. That's the only way out of that situation. I would guess some people do die until the very end. Some people would still not want to talk about it. That the effect on the family member is obvious. They weren't able to talk to the patient well. They weren't able to express themselves well because, it's a taboo topic. It might interfere with their coping and adaptation. Of course, I just told you a lot of things can be exchanged and said without bringing up the idea of death. The other reason why people don't want others to know about their death is because they don't want people to think less of them. In their mind, they're the funny guy, they're nice to be with, and the friends think of him or her this way. It's the life of the party, or a successful person. It's the boss. Don't tell my employees that I'm about to die and I'm lying on bed on a ventilator. So you don't want people to think less of you. That's the reason why you isolate yourself. Don't tell my colleagues that I'm in this room, especially if you're like big shot doctor. You interact with your colleagues usually in conferences and tell them that you just came from the US, paid by somebody else or drug company, and then this is what you want to project, and you've been working at it for all your life, and in your mind, this gives your life meaning. In your mind, you want to die that way because that's your meaning in life, right? And what will happen to that meaning in life of yours if your colleagues realize you're in the hospital bed attached to a ventilator with all sorts of tubes coming out? They actually visit you and see you like that. That particular person that we described would say, don't tell everyone about this, right? People don't want their family members to tell everyone else, their relatives or their colleagues or their friends, even if they're close friends. Now, of course, if you have a Christian or Catholic background, and one comment to that is you should have lived your life in a way that it won't matter how you look. It would have been nicer if your sense of meaning isn't attached to something like that. Because obviously that doesn't last. Now you're trying to hide the reality from them because the person you tried to build up, the persona you created, would be destroyed. Suddenly this persona is not there anymore, and they see you inside the hospital room, so you don't want them to know about it. Just tell them when you're already dead. So at least last interaction with you would be still with this kind of persona that you think gives meaning to your life. If you go go through the Judeo-Christian, Christian or Catholic idea, the suggestion is probably that's not a good goal in life. Maybe you shouldn't work for that kind of meaning in life. Also happens with the people around the patient. They also don't want to think about the death. They cannot handle it. Not just the death of the loved one who's now lying down in bed. That will greatly affect them. Not just that. In their minds, if someone so close to them can die, they can die. So it's actually the fear of their own death. Even doctors and nurses experience that. They become close to this patient, or they work in the hospital, they see so much death. It drains them, not just because of the death of people around them. It drains them because it also triggers something inside them. And that something is, you cannot help but think that you also will die. And you might die the same way, especially if you're talking about the COVID pandemic. And if that thought or that idea sounds very stressful to you, then your mind will defend itself by avoiding that thought or that idea. So the doctors, the nurses, the family member will also try to avoid talking about death or eventual death or bringing up the topic. And of course, obviously, that would cause a lot of problems. Everyone knows it's going to happen, but they don't want to deal with it. They don't want to talk about it until the very end. That prevents all sorts of things from happening, even the good things from happening. The decision-making would be affected. Final goodbyes, unfinished business would be affected. Adaptation and coping of the family member would be affected. Even the doctors and the nurses would also have to adjust, prepare themselves, and cope. And that would be affected. Not just management of the patient, not just getting informed consent. I mean, it goes beyond that. One common intervention in the Western countries or Westernized countries would be the approach of psychology, psychiatry, Western mental health care. Make the patient and family focus on the here and now. Meaning, all these things about what happened in the past, what will happen to you when you're about to die. You're still alive, focus on the here and now. This sounds pretty decent. If you do that, then a lot of things can get unglued. The person can think better because all you need to think about is right now. Just talk about now. That takes out the fear of death because you're not thinking about death tomorrow or the death 1 week from now. Just think about now. Don't deal with that. That's one way of doing it. The problem with that is it's so hard to do because the closer you are to death, your body's going to tell you that you're about to die, the harder it is to think about it. The other problem with that is it limits the ability of the pastoral care provider, or the pastor or the priest to help you out. They're the ones who try to help you transcend death, but you don't want to think about transcending death because you don't want to think about what will happen tomorrow or 1 week from now. So that's, of course, the problem with that. But that's not the topic for today, and we'll just deal with that some other time.